work that India is doing such a great job. I must congratulate again to Dr. Purnima Satoskar that you are taking up such a wonderful subject. That is, the pap smear, and I think I need not say so much of will be, said by the or discussed by the authorities here. Sarya Madam herself is present. Sarita is conducting the panel discussion and everything. But as a international president elect, my experience, I really want to give one great message. A small work at your level. Even this webinar, it will be taken into account, because when I started, I thought, no, how can we win? Then I thought, why should we negate ourselves? We are very important. We do such a great work. We go to the society, we go to the rural areas, we go to the suburban districts and everywhere. So why not? And that why not has brought us the laurels. It brought us the very coveted post of history of India, that is the president elect of MWIA. Then the another award to Madam as her committee as a MWI for the oncology. Third award is for the her story. Madam's name was recommended by the AMWI for her cancer control work. That award, and also the Golden Jubilee Award, 9 awards by the Kolkata and Mumbai, and 5th award was given to me. Very politely, I want to mention that my extraordinary contribution and work. So that award is given to me, a special award by the MWI, that please keep doing this good work. Don't consider that always a big conference are going to make a difference, but small, everything will make a great difference. And I think with these words, I wish all the success to such a great webinar.
Thank you, madam.
Thank you, madam. Fantastic work on your part.
And I think you all contribute to my success, to our success. And I think India will do a great job as far as the international work is concerned. Thank you very much.
Thank you, ma'am. Shivani, can you change the slide? Thank you, madam, and congratulations again.
Yes, ma'am.
Congratulations to all of you. Now, 1 minute, can you just permit me? Please permit me to show that you have already shown, but for
Sure, ma'am.
Just a minute. So this is, you can see, can you see here?
Yes.
Yeah, see the certificate awarded to the Chair of Elimination of Cancer Special Interest
Group.
So this is, I think, the best, award which we can really get as far as the India is concerned. So this I want to show you.
Thank you, madam. Thank you. Shivani, can you please change the slide?
Yes,
presentation, CV.
Yes,
Dr. Usha Saraya's CV, please. Next. I have great privilege in introducing Dr. Usha Saraya, who does not need an introduction. She's consultant obstetrician gynecologist at Breach Candy Hospital, Saifi Elizabeth Hospital. She's founder member and past chairman and past president of ICOG, past president of MOGS, Foxy, ICOG, IAC, and AMWI. And most important, she started the cytology clinic at Kama Hospital in 1970 and developed it to an internationally recognized center. She had many international and national awards. More important, I can see she is awarded Living Legends by IFCPC in July 21. I request Dr. Usha Saraya, madam, to please say a few words.
Thank you very much for the generous introduction. It's a subject of today's seminar is of great interest to me, and I'm very happy to participate. And I'd like to thank Purnima Satoskar and Archana and Anju, and the support that they have got from AICC, RCOG, and the MWI to organize this. It's a relatively new subject, and not too many people are interested in it, but you have collected a whole lot of experts today to discuss this issue. And I belong to all these organizations for many years. And although you call me a guest today, I could easily qualify to be the chief host because I am one of the senior most members of all these organizations and still active and attending your meetings. Our
Thank you.
conveners, Vijay and Anju, have really put in a lot of effort, and they've collected all the experts on the subject to discuss these cases, share their experience, and enlighten everybody on how to go about managing the cases. Now, we
Thank you.
also have an MOC in Dr. Vidhi. I hope she's here.
No,
Like,
ma
she'll have a
she,
jump.
I think Vidhi was down with flu.
Not able to come, I know, something like
Yes,
that,
yes,
because
yes.
it's very difficult to keep all these experts in control of the discussions and to move the discussions
Well,
forwards
true,
and
true.
keep to time. It's a very
Yes.
tough decision to do. And I also wish to thank Corona Remedies because they have good products and they are good um, uh, they are keen to do scientific programs and they participate actively and give very good service, and I'd like to say. Now, I
Thank you.
know we're going
Thank
to
you
have,
so much.
sorry, we have a lot of interesting program coming up, so I don't want to take much time. But are you hearing me or is there
Yes,
a
Yes,
ma'am.
second?
yes, 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 we can hear you, ma'am.
Noise. I just want to talk about one scientific information today, which is of significance because it is a combination of pap smear with immunohistochemistry. It is called Syntec with cytology or a dual stain technique for pap smear. You know, pap smear was discovered, you know how many years ago, but it has not remained static. It has progressed, it has developed, and many new things are coming up. And it is giving us a lot of information. So this Syntec with cytology, not only will you, as you screen that pap smear, not only will you know the degree of the cellular abnormality, whether low grade or high grade, it will also give you whether the HPV has affected the nuclear change and pray straight away give you some guidance about how serious the condition is. So I just thought it's good to know that there is progress going on in this subject. And if we get all these investigations within our clinical use, it is going to help the patient also a lot because we will not be doing unnecessary treatment and nor will we deny good treatment to a person who needs it. So I just want to end by saying
Thank you.
that what is in the realm of research today comes into clinical practice tomorrow. So we are
Yes.
on the verge of getting this research technique into our practice now. So with this, I would like to just wish you all the best. And I'm
Thank you,
sure
madam.
we'll have a very good discussion on the subject. And
Thank you,
thank you
ma'am.
very much for all the remarks of the AMWI thing. I have worked with AMWI and with MWI for over 5 to 6 decades. So it really has been a great experience for me and I shall cherish it all my life. Thank
Thank
you.
you. Thank you, madam. Thank you for being
Thank
part
you,
of
ma'am.
today's
Can I just
program.
request Corona to mute the people who are not? I think Dr. Vadvikar's needs to be muted and anybody else because that is disturbing the conversation.
Okay, ma'am. Yeah.
Yeah, so can we change to the next slide, Dr. Archana Baser? I welcome Dr. Archana. Hi, ma'am, where are you? Hi, Dr. Archana. I welcome Dr. Archana for our today's program.
She's in another webinar, so you can introduce her and whenever she joins, we'll welcome.
She messaged me that she has
Okay.
joined
Okay.
at 8 o'clock, but I think she might have left for there. So I will introduce her to people. Dr. Archana is Fellow Representative Aicc RCOG West Zone, and she is Vice President FOXI, Chairperson MP ISAR, and Joint Secretary ISPAT 2527. We will again introduce her and say hi when she joins again. Shivani, can you change to the next slide?
Hi, Anju.
Hi, ma'am. Hi,
Hi.
ma'am. Just now I finished introducing you. I
I
thought
know.
you have left. Yeah, yeah.
All the best.
Thank you. Thank you. Be here as an expert. At
Yes,
least
I
for some
will. I'm
time.
here.
So
So now
before,
we will start with the Vandana.
yes, so before starting the academic session, we will light the lamp and pray to Saraswati Ma. Please start this. Voice is not there. It is muted. Hi. Yeah. Thank you, Shivani. We can go to the panelist CVs and start the program of panel discussion. Yes. Next slide, please. Dr. Amita is traveling. She said she will be joining late if possible. Can we change to the next slide? I welcome Dr. Gitanjali. She is Medical Officer, Department of Preventive Oncology, Aicc Tata Memorial Center, Navi Mumbai, and she is Honorary Colposcopist Cytology Clinic at Kama Hospital. She is FOXY and IFCPC, WHO, ISCCP certified master trainer for colposcopy and treatment. She is recipient of Golden Jubilee Award. Welcome, Dr. Gitanjali. She was here. One second. Is she muted?
Yeah, I'm there. Thank you very much.
Yeah. Dr. Shivani, please change to next slide. I welcome Dr. Sarita Bhalerao. She's consultant obstetrician and gynecologist at Bhatia, Saifi, Reliance, Breach Candy Hospitals, Mumbai. She's secretary ICOG. She's immediate past chair AICC RCOG West Zone, president Mumbai OBGY Society in 21-22, past president AMWI branch, Mumbai branch. Welcome, Dr. Sarita. Hi, is she muted? She's muted. Dr. Vijaya is already introduced. Next slide, Shivani. Yeah, Dr. Samar Gupte, he's MBBS MD OBGY from Mumbai University. He has done his Homi Bhabha National Institute Fellowship in Gynae Oncology from Tata Memorial Hospital, Mumbai. He's trained at UCLH London and Milton Keynes General Hospital, UK. He's attached to many hospitals in Mumbai, including Hinduja Group, Surya Group, and Breach Candy Hospital, Vadia, etc. Welcome, Dr. Samar.
Thank you so much, madam.
Welcome. I request Dr. Vijaya to introduce our panelists further.
Thank you, madam. It's my privilege to introduce Dr. Meeta. She is a senior consultant obstetrician and gynecologist, and she is affiliated to Tara Clinic, Lakshmi Clinic, Cloud9 Hospital, Jupiter Hospital, and she's PG teacher, and she's associated with the NGOs. Welcome you, madam.
Good evening, everyone. Nice to be here.
Yeah, Shivani, can I have the next slide, please? Yeah, it's my privilege to introduce Dr. Santosh Menon. He is a professor of pathology and uro-oncology disease management group, and he is affiliated with Tata Memorial Center, Mumbai. His vast experience in oncopathology, uro-oncopathology, gynec oncopathology, and immunochemistry, many national and international credential as it credit, and he has more than 150 publications. Welcome you, Dr. Santosh.
Thank you so much. Thank you. Happy to be here.
Yeah.
And again, it's privilege to introduce my own friend, Dr. Manzar Altamas Sheikh. She's a consultant obstetrician and gynecologist and fertility specialist, honorary consultant at Saifi Masina Hospital in Mumbai, and chief OBGY MS Neolife Super Speciality Clinic in Mumbai. She has co-authored many articles in the textbooks, and she has won LM Shah Prize in annual Emojius conference. Welcome, Dr. Manzar.
Thank you, Vijaya ma'am, for that kind introduction. Good evening, everyone. Thank you, Dr. Anju, for having me here.
Welcome, Dr. Mansar.
Next slide, please, Shivani.
Yeah.
Yeah.
So
Now
everyone, we will
go
start the
with
panel.
the case discussions.
Yes, yes.
Anju ma'am, shall I share your PPT?
Yes, yes. And then can I change or you will have to change the slides?
Ma'am, I have to change them.
Okay, so please share because I am finding it difficult to share. Yeah, put it on slideshow, please. Hi. Yeah. First, next slide, please. Yeah. So our first case is Mrs. ABC. She works in a developed country's Indian consulate, 51-year-old. She came with history of pain lower abdomen for 3 months. She brought her MRI report, which showed uterus anteverted 43 into 68 into 71 millimeter size. Junctional zone was diffusely, please stay in the previous size. Yeah. And junctional zone was thick. Maximum width was 12.8 millimeter, ET 9.2 millimeter, and IUCD in C2. Cervix was bulky with multiple non-enhancing cysts like chronic cervicitis. She has 2 vaginal deliveries, 22-year-old and 18-year-old children. She is using IUCD for last 18 years. And menstrual history, she is getting irregular cycles and dysmenorrhea on first day. Change, please. No significant medical history. In surgical history, she underwent conization of cervix 3 years ago in her home country. PAP and HPV from that time is not available. Colposcopy diagnosis was high-grade lesion. Then conization was done, which was histopathology was hyperkeratosis, aparakeratosis, squamous metaplasia. She is on annual PAP and HPV testing. Reports not with her. No drug allergy. And in personal history, she smokes cigarettes almost 10 to 12 daily for last more than 18 years. She's separated and lives with a new partner. Next, please. On examination, cervix was hypertrophic, IUCD thread was seen, PAP and HPV was taken, uterus bulky, mobile, non-tender. Pap smear report came as NILM, moderate inflammation, HPV came as genotype 16 and 18 positive. Next, please. Next. Yeah, so my question is to Dr. Sarita, what next would you do? Dr. Sarita, you are muted.
Yeah. Sorry. I'm
Yes.
here.
Yes.
Can you just go back to the previous slide a little bit? Yeah.
Shivani, yes.
Yeah. So here we have a PAP and she's got an HPV test is also positive. So we need to go for a colposcopy with the directed biopsy. And maybe I think also, yeah, I think that's initially, I think there was nothing in the uterus, no?
So MRI was showing some adenomyosis and bulky cervix with the cysts in cervix.
Okay. Yeah, so I think I'd go for a colposcopy definitely right away.
Right. Thank you.
Yes, 51.
Yeah, so since she also has AUB, abnormal bleeding, so we also did hysteroscopy, DNC, ECC, and colposcopy with biopsy. Please change, Dr. Shivani.
Next slide, Shivani, please.
And IUCD was removed because that is also contributing to inflammation. Next slide, please. Yeah, what more you will advise her?
So if I...
Hello? Yeah.
Yeah.
These are her colposcopy images. I request Dr. Samar to please describe these images.
So on the face of it, I must say that somebody who's had bone biopsy, and when you now do a colposcopy again, I think it's extremely difficult, to actually get to the transformation zone. And even in these images, the transformation zone is not very easily seen. And and it obviously, cervical fibrosis is there after the last procedure. But if you look at it, once that that forceps is put inside and you've opened it up, I think with acetic acid, there are those areas which you've highlighted also. I think at 9 o'clock, especially,
Yes.
acetowhite in the same area is Lugol's positive. Though it looks acetowhite and Lugol's positive, it doesn't look extremely dangerous. But still, yes, obviously one has to biopsy those areas. So I think that's the way I would proceed. I would definitely do some sort of biopsy on those areas that you highlighted.
Yes. Shivani, next slide, please. So these are more images. The same thing is seen. Transformation zone is type 3 and
Yeah.
lower grade lesion at 9 o'clock is seen. Next, please. Yeah, Dr. You have described. Dr. Gitanjali, Dr. Samar has partly covered the challenges.
Yeah.
What are the challenges in a previously treated patient where we do a repeat colposcopy? And how do you tackle them?
In colposcopy, this is one of the challenges in the treated cases of CIN, either ablation or excisional leap or conization, because the cervix anatomy is mildly distorted and the transformation zone you are excising. So the scarring and the fibrosis will be there to look in for the acetovite lesion, and the scar also will give a diffuse acetovitening. So it is very difficult to detect the lesion. So in these cases, while we have to take care, even the endocervical speculum, in this it is not bled because of the scarring. Even endocervical examination with the speculum is also very difficult. So in these cases, if you see a white, any suspicious lesion, you take a biopsy, yes. Otherwise, while taking a PAP also, it is a challenging. Here we have got inflammatory. It is really doesn't mean that the patient is not having the lesion. She might have, because the residual or recurrent lesions usually occur in the endocervix. So proper brush cytology has to be done to get the accurate proper PAP report. And while doing a colposcopy also, you can take, even if you don't see anything, proper endocervical curettage has to be done. In this patient, good, she has had a hysteroscopy. While doing a hysteroscopy, if you sprinkle through the syringe the acetic acid at the end of the procedure and re-visualize the endocervix, you can see some patchy lesions, acetovite lesions.
Thank you.
Can be done.
Yeah, it's a good tip, Dr. Gitanjali. Thank you very much. Just go to the next slide, click again. Yeah, so you have explained everything, maybe under anesthesia because she will require manipulation.
Yeah, it is a painful.
Yes, next please. What is adequate colposcopy, Dr. Manzar?
So adequate colposcopy is the one wherein the entire cervix is visualized. We are able to see the transformation zone and the squamocolumnar junction. If as Madam said, if the transformation zone has moved inside the endocervix, then we need some manipulation to expose the transformation zone completely.
Yeah, thank you. Next slide. So ECC and hysteroscopy DNC done, and leap excision of white area at 3 o'clock and 9 o'clock was done, specimen marked and labeled. Histopathology came as endocervical curettage was benign, inflamed ectocervical tissue, no CIN malignancy. Endometrium came as benign endometrium, fragments of ectocervix exhibiting CIN1 or L-sil, with cervix lesion came as CIN2. Dr. Sarita, what next would you do with this histopathology report?
So here we are seeing a low grade lesion. We are also seeing CIN2. She's also HPV positive. So you discuss the options with the patient, and one can wait and follow up and see. And basically you've already done a leap, so that area which is abnormal has already been excised. So yeah, so the margins, I think we don't know about those.
Yes.
But maybe that lesion has been removed.
Yes, yes.
So one can wait and
Yeah, so we had some doubts, so we did a review HPR. Next slide, please. Review HPR came as the section show strips of squamous and columnar epithelium and small fragments of unremarkable endometrium. There is patchy expression of P16. HPV is not expressed. No evidence of dysplasia or malignancy. This was reported by Dr. Borges. Can we go to the next slide, please? Yeah, Dr. Menon, this was reported as CIN2, and this is the slide picture of CIN2 reported by the first pathologist, and second pathologist said no dysplasia. Hello, Dr. Menon?
Yeah. Can you hear me, Dr. Anju?
Yes. So this slide.
Thank you for having me here. Thank you for having me here.
Welcome.
So I would definitely not agree that this is SIN2. First and foremost, it's a very fragmented biopsy. It's not very well oriented.
Right.
What we see here is just squamous epithelium showing some mild ATP. And when I say mild ATP, some would likely call it a SIN1. Some would just pass it off as inflammatory change or a long-standing change in person who has been on IUDs and all that stuff. So I don't think this is SIN2 for sure.
Okay.
And generally in practice, we would add a P16 in such doubtful cases where you are contemplating a SIN2. But so if P16 lights up this very in a block positive way, P16 IHC, then we would really start considering that this is indeed dysplastic. So, but on morphological basis, if I don't have any IHC, I would not call this as SIN2.
Okay. So next slide, please. So how much patient is cost? I don't know, you may not be knowing, but if you have any idea, P16
P16
would cost
IHC
how
costs
much?
for a private category patient costs around 1,200 rupees, 2,600, I think.
Okay.
Yeah, it's a little expensive antibody, but then it's very useful and it's sort of indispensable for a cervical biopsy.
Plus your histopath charges.
Yes. Yeah.
This is HNE. This is IHC charges. This is P16 IHC charges.
Okay. Thank you, Dr. Menon. So that will be the discretion of pathologists to do P16 or not, looking at the morphology. IHC. Yeah. What clinical information clinicians must provide with every biopsy? Dr. Santosh.
Yeah, I think we need the age and the reproductive status of the patient, and generally we would like to know the via Willi findings. Although many times it does not correlate, I would say it's not that every time a via Willi positive would turn out to be a SIN lesion, but via Willi with the comment that it looks like a low grade lesion, high grade lesion on a request form does help us form an impression, or we look more ardently for it. We sometimes do deeper cuts of the tissue to look at these things, whether we are missing something or not.
Right. Even her first colposcopy was high-grade lesion, but
Yes.
histopathology of cone was negative for any CIN. So this time, next please. And how to orient a cervical biopsy specimen.
So a small biopsy specimen, which is 2 mm, 3 mm, we don't orient it. We orient a conization specimen or a leaf specimen. It is oriented, sent generally with a thread or 12 o'clock, and then we would cut it open, and then we would submit it, completely examine the whole cone or the leaf specimen which is submitted to us. But a small tiny cervix biopsy is not oriented generally, it's just submitted entirely.
Okay, thank you. Next slide, please. Can we know if this high-risk HPV is transient in her or it's a persistent infection? Is there any test available for knowing that?
The IHC P16 will help us.
Okay.
Whether it is a progressive disease or...
Yes. So if I may add, P16 is a surrogate marker for saying that this is sort of the DNA is integrated into this. But again, it is positive in 90% of the cases where it is, and it is a surrogate marker for HR-HPV infection.
But not a marker of persistent infection.
Persistent, we would only say that only when we have taken multiple over different time periods, probably with HPV testing and all. I don't think we currently use any IHC marker which tells you whether it's a persistent infection.
Okay. Thank you. Next slide. How will you follow up, Dr. Samar, this patient?
So for this patient, my follow-up will be in two parts. One is obviously the immediate follow-up because she's had a procedure. So maybe call her after a week or 2 weeks to see whether she's doing well or not. And on a long-term basis, obviously she needs a pap smear and an HPV after 6 months. However, I would still go back to the discussion that Madam Sarita Bhalrao had, where we don't know whether, the leap was adequate, whether the base was negative. We don't know about that. So I'm just assuming that that was adequate and everything was removed. Then yeah, I'll call her after 6 months to get another smear done and see how she's doing at that point of time. I think that would be
What
the most reasonable option.
and what other advice regarding her lifestyle you can suggest?
No, I think she's 51, she's a smoker. So obviously stop smoking is the first thing that I would tell her. I mean,
Yeah.
and at the end of it, I'll just tell her, come back for another
Yes.
smear. Don't disappear on us. That's all.
Yes. Yes. Thank you. Thank you.
Also carry your reports wherever you go.
Yeah.
It's just
Yes.
continuity is a problem. She's
I
changed
know.
countries and she's gone to different doctors. She's had the procedures done, so she's compliant with follow-up.
Yeah.
But
Yes.
like we read an old photograph and see the difference with a new photograph, in colposcopy, we always give the images. And it's great that we have good pathologists with us, but sometimes, especially having worked abroad for 10 years, when people go back, they say, India mein kiya hai. No. You have to have, we are following every protocol which is followed around the world, and it's important for her to carry her notes with her wherever she goes. Just so
Yeah.
that
Thank
And
you.
also, madam, we need to emphasize about follow-up on a regular basis. She should not be lost to follow-up because she's had a procedure a couple of years back and she has returned with another lesion on her cervix. So it should be emphasized that she should be under regular follow-up.
In
Yes.
fact, I will go to the extent of saying, Madam Nakhre, that it is the opposite. In our country, when we do things, we give them the reports, the papers, everything.
That's
When
what
they
I'm
come
saying.
from abroad, they don't have anything with them.
That's exactly
It's
my
all in the
point.
NHS, it's all in this.
But she has to carry them, na?
Yeah,
She's
yeah,
changing
absolutely.
countries, so sometimes she has to understand the importance of keeping them.
Yeah.
Yeah. Thank you.
And,
Next.
and this lady also has a history of AUB adenomyosis. If she
Yes.
becomes symptomatic, there's a role of hysterectomy also.
Yes. 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 Thank you. Thank you.
51.
Yeah. So, Dr. Manzar, can you tell us the indications of colposcopy?
So indications of colposcopy, basically looking at the cytology report. If the patient comes with persistent abnormal cytological report, persistent atypical squamous cells of undetermined significance, or a positive high-risk HPV subtypes on the testing, atypical glandular cells, low-grade or high-grade lesion, or in a patient with invasive cancer or presence of malignant cells on the cytology. Other indications include symptomatic patient who's had postcoital bleeding, intermenstrual bleeding after a thorough gynec investigation has been done, and a patient who has presented with a positive VIA or VILI. And if we look at other indication, it could be a diethyl stilbosterol exposure in utero. These are some of the indications for colposcopy.
Thank you. Thank you. Can we go to the next slide, please? Yeah. So, Mrs. XYZ, this is our second case. 35-year-old homemaker, studied till 5th standard, referred from fertility specialist with pap smear report of HSIL. Obstetric history, nulli gravida, married for 8 years. Menstrual history, regular periods, no concern. She has undergone laparoscopic salpingectomy, both tubes removed in view of recurrent tubal ectopic pregnancy. Personal history, she's a Mishri chewer. Husband is a class 4 employee in BMC. Dr. Sarita, what next? I'm asking again to Madam. What
No,
next?
that's fine. So here we have a patient who's basically come for fertility, but you
Yes.
find that she has a high-grade lesion. Now, a
Right.
high-grade lesion takes priority, according to me, over the fertility, and that needs to be sorted out first. And she
Yes.
needs to be counseled regarding this. And if she has a high-grade lesion, we do need to do an HPV testing and then go do a colposcopy with maybe the biopsy or a leap, depending on the colposcopy findings. And then once that is sorted out, she can go back to the fertility specialist.
Thank you, madam. Next slide, please. So we HPV test or direct colposcopy. Anyone wants to take this question? Madam has answered that. Any other panelist has any other opinion?
Because the cytology is a highly specific test,
Yes.
can directly go in for a colposcopy. In
Yes.
in the management, HPV test won't help it. Only in the follow-up it might help.
So, okay, next slide, please. So on colposcopy, adequate colposcopy was there. SCJ was fully visualized, large aceto-white lesion on anterior and posterior lip involving 4 quadrants. Next slide, please. Dr. Manzar, can you describe the images in next slide?
Sure, madam.
Yeah. Next slide, please.
So if we look at the images, the first images after, I think the images are
Mixed.
kept
This one,
mixed. Yes, the
yes.
first image, if I go from left to right, the first image is after application of Schiller's iodine. Here we can see that the lesion is extending in almost all the 4 quadrants, and it is a Schiller pale area. Whereas in the second image is after application of acetic acid. Again, we can see the lesions are extending almost in all the 4 quadrants. Between 11 to 1 o'clock, there is a dense aceto-white areas. The margins and the borders are sharp. If we zoom in the image, maybe we would be able to see some abnormal vascularity and mosaics also, which I am not able to see very clearly here. So overall, looking at the post-acetic acid and Schiller's images, it does look like a high-grade lesion.
Okay, thank you. Thank you, doctor. Next slide, please. Yeah, so colposcopy impression was a high-grade lesion. Next slide. Dr. Meeta, would you like to do an excisional biopsy with LEAP or multiple punch biopsy in this patient?
Definitely, it's a high-grade lesion. For this, I would definitely do an excisional biopsy, making sure that I cover the entire with LEAP or LETS. But also, I will look out for satellite lesions. And in case there are other satellite lesions, then take a punch there. But definitely an excisional biopsy.
Thank you. Dr. Samar, if LEAP is done, what should be the depth of LEAP?
So ideally, when you're doing a LEAP, the entire transformation zone should be included. And if you can get that out, it's good enough. Depth, I mean, I've also been looking at literature and they talk of 7 to 10 millimeters depth. But if you read it, 7 to 10 millimeters for a small specimen is a huge range. You know, it's the 30% range is a big range. So I think the whole idea is to get enough depth so that the base is clear. I mean, so I think that's about it. If you can cover the entire transformation zone, you're going to get adequate depth also, I feel.
Okay.
Just one thing, you have not mentioned anything about the green filter.
Yes, green filter was not showing any abnormal vessels and plain image was showing a Nabothian cyst.
Depth would also be based on that, isn't it? After you've seen the green filter, you can also take a deeper, if you feel that the vessels are more aggressive, then you would go deeper. So.
Okay. Dr. Sarita, is there risk of incompetent os following LEAP, and is stitch is needed in all of these patients when they get pregnant?
So yes, there is a risk of a slightly higher risk of incompetent os, and so we have to keep that in mind when she gets pregnant and evaluate the cervix. Of course, if a small LEAP has been done, then the cervical length which is left behind may be adequate. But if it has been a large LEAP, and you can always check cervical length on ultrasound and clinical, and then decide about the stitch. I don't think that in all patients you would like to stitch, but sometimes if you may want to err on the safer side and take a stitch, nothing wrong.
Okay, thank you, ma'am. Thank you. Next slide, please. So this was her histopathology, high-grade lesion, CIN3. Next. Can you go to the next slide, please? What next? When can she go for embryo transfer?
So I think, again, this depends. She has to recover from that. Once you have removed that whole area, and we are confident that our treatment is over, then she has recovered and that it has healed, she can go for the embryo transfer.
Okay. Okay. What for? Yeah.
Sorry, Dr. Anju, if I can intervene a bit. When you do a LEAP or a cone, I think there has to be comment on margins of excision.
No, so this was not a cone or LEAP.
Okay, this is just a biopsy? This was not a cone?
Yes, with the knife, not a punch, but with the knife, I took biopsy from the
Probably I
most
read it wrong.
painful
I thought
area.
you did a LEAP and then there was no comment.
No, it was not LEAP. Yes. So panelists can tell us about colposcope, which one is better, binocular or digital colposcope? Anybody? Dr. Gitanjali, Dr. Sarita?
Yeah, we have learned, come up with a optic colposcope. But the learning curve compared to video colposcope is little long. But optic colposcope is very much better. Clarity is there, and the three-dimensional pictures are there, and you are seeing through the scope, and the vascular changes, everything is seen better.
Right.
But because of the video colposcope, they got familiarized, and it has reached many gynecologists and the community. It is easier to learn. So in that way, video colposcope, and even nowadays we have digital colposcopes and handheld colposcopes, and the things have become simpler.
I think documentation is also very important now. And with the binocular, you are handwriting with the diagrams and things. Today, people want images, they want CDs.
Yeah.
And I think that is important.
Right. Okay. So Dr. Manzar, little bit about basics, how to prepare acetic acid and what strength it should be, and how to get the Lugol's iodine. Dr. Manzar?
Yeah. So for preparing acetic acid, we need to mix 5 ml of glacial acetic acid to 95 ml of distilled water. It should be freshly prepared as much as possible. And for preparing Lugol's iodine, we need to take 1 part of iodine to 2 part of potassium iodine. Please correct me if I'm wrong. Yeah.
Correct. It is Lugol's iodine ready-made is available at Amazon. I got it and it was very good. I used it.
Yes, madam. We are also using those ready-made bottles these days.
Yes.
Otherwise, to prepare, you need potassium iodide and iodine crystal and distilled water or boiled cool water. 1:2:10. 50 grams of iodine crystal, 100 grams of potassium iodide, and 1000 ml of 1 liter of water. You have to mix it for a longer period of time. It takes half an hour to prepare. And it will last for a year if you use it.
Okay. Keep it away from sunlight and in a dark brown.
You have to color it. Yeah, brown color.
Yes. Yeah. Going to the next case, Mrs. ABC, 35-year-old, Nalli Gravida, married for 2 years, came with complaint of heavy flow in periods, mild dysmenorrhea. She wants to conceive, and sonography pelvis showing bulky uterus, volume around 120 cc, both have ovaries in pouch of Douglas. Left ovary has a persistent cyst of around 4 centimeter for more than 6 months, probably endometrioma. She has received 3 months of birth control pills. On examination, her cervix is hypertrophic, large ectropion, uterus is bulky, mobility restricted, PAP with HPV was taken. Next slide. Pap smear case came as NILM, moderate inflammation, HPV 16 and 18 detected. So what next we should do for her? Dr. Meeta.
I think this is a lady with a few problems. I mean, it's the cervix, it's the uterus, and basically it's her endometriomas. So before we decide to do anything, we need to sit down and talk to them, saying that under one general anesthesia, maybe we can do a few. You have a look at the cervix, do a colposcopy, take targeted biopsies, do a hysteroscopy, check if there is um, any issues there, do a laparoscopy and sort out the fact that her endometriosis can be drained, and check for tubal patency as well, because at one sitting we can do a lot more, not just for her cervix but also the uterus and the fertility. And since she's HPV 16 and 18 detected, I mean, I would definitely do a good colposcopy and targeted biopsies.
Thank you. Can we go to the next slide? Colposcopy, biopsy, hysteroscopy, DNC, laparoscopy, fertility enhancement, as you said, is suggested. Next slide, please. On colposcopy, cervix was not fully visualized. SCJ visualized fully after manipulation. Large aceto-white area between 3 and 9 o'clock. Small polyp at 7 o'clock. No abnormal vessels. Polypectomy, cervical biopsy taken, DNC done. Next, please. Dr. Gitanjali, can you describe these images? They are not in order. Yeah. Third image from left is a plain image. Other is acidic, and the filter the last.
It is a large T-zone with a polypoidal endocervix, and there's a mild acetovite area more in the posterior T-zone, and
Correct.
maybe few fine mosaics are seen. It's not a clear picture.
No, not
And
at
the Schiller's test is positive. It's a canary yellow.
correct.
If you score the lesion, it may go in for CIN 1 to 2.
Okay. Thank you. Next.
Is
Yeah.
there a polyp, ma'am?
Yeah, it's a polypoidal
Lip.
endocervix anteriorly.
Okay.
That is
Posterior lip. Posterior lip has a polyp.
anteriorly. There's a tiny polyp in the endocervix.
Yes. So is this change because of occipils, cervix,
Possible,
ectropion?
possible.
Yes, yes. Next slide, please. So histopathology came endometrium, secretory phase, cervix came within normal range, polyp was benign, ulcerated, endocervical polyp. Next slide. Dr. Amita is not there, so anybody can take. What is the chance of HPV getting negative over time in this patient? She's 35-year-old, first time detected HPV positive. Dr. Samar or Dr.
Madam, I
Sarita?
think there is no guideline that is going to tell us whether it's going to become negative or not. But I'm just conjecturing that since the cervix biopsy was normal, there's no rollover P16 stuck in there. So there is a fairly decent chance that it can become negative, but who knows? I mean, I think
Correct.
it's up
Yeah,
for
so
grabs.
generally
I
putting
think
into perspective, the chances of warding off an HPV infection is to the tune of 85-90% in over a period of 1 year, 1 to 2 years. Generally, most of the people would ward off that infection. The local
Yeah.
immunity, the immunity of the patient would give.
Yeah,
But the
I was
time
going to
limit
say the
can
same
vary.
thing. That we
You
know
have
that
to,
almost 95 to plus
Yeah.
percentage of
90-95%.
patients will
That
clear
chance.
it in 2 years.
Yes.
Yes, so this will be important part. This should be an important part of counseling when they get this HPV positive report.
And also depends upon them having a good immunity and practicing all the other lifestyle changes as well.
Good
Yes.
healthy diet, antioxidants, etc.
I just have one. Can I
Yes.
say something?
Yes, yes.
Sometimes if you have a young girl, 35, single girl, multiple sexual partners, large erosion, HPV DNA positive, give her some antibiotic, pap smear just comes as high inflammatory. And then it's important, what I'm trying to emphasize is follow up. Because
Yes.
sometimes it may be HPV DNA negative, but that cervix remains like that. And then it's very difficult to counsel for a biopsy or a colposcopy also. While you're trying to, it can be, this lady is fine. She had a polyp which could have triggered off the inflammation. But I'm talking about the other spectrum where counseling when you have HPV DNA negative, but you see a lesion which is persisting and not going away. Sometimes we need to also talk to them saying not just HPV DNA, but the lesion itself may need a biopsy. This is a completely different scenario I'm suggesting. So yes, HPV DNA goes away over 2 years' time, but also can leave behind a disease which can be picked up a little bit later. So follow-up is what I want to say.
Yes, yes. Thank you. Thank you. Next slide, please. Yes, how you inform and counsel HPV positive report to them. I think this is covered. Next slide, please. Anybody wants to add anything into that? One common question and difficult question to answer is how I got this HPV. Is my partner not, is he having some other relation outside? That part we should be able to answer to them. Yeah. Next question is, in another patient seeking fertility treatment, if cervix looks clinically normal, can we proceed with fertility treatment and reserve colposcopy biopsy for later?
No, I don't think. I think that no, she was
No,
HPV
this is different
HPV.
patient. I'm
One
saying
sec, I'm confused.
any other patient who's coming for fertility treatment and swab is saying HPV positive, cervix looks normal.
Yes,
So
then you can continue because HPV is likely to clear. No, we cannot
Right.
hold up the fertility treatment
right,
for that.
right. Unless the pap smear is showing some high-grade lesion.
Yes.
Yes.
Thank you. Next slide, please. Next case, Mrs. XYZ, 37-year-old, nulli gravida, married for 2 years, comes with repeated vulvovaginitis, treated twice, has a traveling and hectic job. PAP HPV came NILM, moderate inflammation, HPV 33 positive. Colposcopy done, cervix was fully visualized, SCJ seen complete, low-grade lesion, biopsy taken. Next slide, please. Anybody can describe these pictures. There is
This
no...
is a clear picture. Yeah.
Yeah.
It's an adequate colposcopy, and you can see a mild acetowhite areas all around the covering all the 4 quadrants of the cervix.
Right.
And I think there are some gland openings, prominent gland openings are
Yes.
also seen, and partial uptake of the lugols. So
Yes.
it's most likely to be a low-grade lesion.
Yes. Okay. Thank you, doctor. Can we move to the next slide? In this patient, can we do one visit treatment like biopsy followed by cryo or thermal coagulation or LEAP? In this particular patient, she's 37-year-old, not having any children, is planning pregnancy after a year.
Yes, I think you can because it does seem to be a low-grade lesion and it's an adequate colposcopy.
So we can do a cryo or thermal.
Yes.
Okay. Next, please. What other advice would you give her? Meaning, I think we have covered that lifestyle and control of infections. Is there a role of HPV vaccine for this lady, Dr. Meeta? She's HPV 33 positive, 37-year-old.
I think if she has, can you hear me?
Yes, yes.
Put myself off the thing. Yeah, I think, yes, everybody, there is a role of the vaccine. She's 37. She's HPV negative, 33 positive.
33.
Yes.
Yes, I would advise her a general lifestyle and would advise her the vaccine.
Yes, with the thought, we'll explain that she will need follow-up with pap smear HPV, and vaccine is not therapeutic and will not cover all. Okay, next slide, please. Role of interferon alpha in treatment of LCIL HPV cure, anything like that? Anybody has heard?
So again, I've just read about this, madam, and I don't think there is any hardcore guideline or anybody who's giving any advice as to the way one goes about doing it. So as far as I'm concerned, it is something that I would just like to read and know more about. But if anybody else on the panel or anyone else has a better opinion about that, I would be happy to, take that under advice.
Yes. So this, I came across a paper from China. I have written to them, please give details. I have not got any reply. But other than that, I have never heard of any treatment. And I feel interferon alpha giving for LCIL is little too much rather than there are other treatments available. Yeah. So this is an algorithm. If we do a primary HPV screening and it comes positive, what we should do, it's a big busy slide. I would suggest to go on Foxy GCPR and go through this algorithm. Next slide, please. Yeah, so now we'll do cases with abnormal pap smear. I request my co-moderator, Dr. Vijaya, to take over. These slides were provided by Dr. Amita. I think she's still not here. So Dr. Vijaya, please take over.
Yeah, thank you, madam. Sure. Now we have this case scenario. A 37-year-old executive married for 3 years. She is nulliparous, non-smoker, on OC pills, underwent screening for cervical cytology, LBC. And next slide, please. We got this report. So, Dr. Santosh, can you tell us like how you will read this slide?
It's very clearly written. It's an ASCUS slide. ASCUS is somewhere where which is short of LCell. To we put it in a very practical sense, something which is a little less than LCell. It is showing some nuclear abnormalities. There are some nuclear enlargement of these cells. As you can see in this cell, there is some nuclear enlargement to the tune of 2 to 3 times the size of an intermediate cell of cervical origin. When you find these cells and you find them in very less numbers, and when there is no typical coilocyte, that's when you call them ASCUS. So as a general rule, in any cytology lab, the ratio of ASCUS to cell should be around not more than 2 to 3 ratio. So you should not be undercalling or overcalling ASCUS.
Correct. Next slide, please. So, Dr. Geetanjali, madam, can you tell us like what are the options available for the management of ASCUS, and which one you will prefer to do for her?
Well, you can go in for a repeat cytology in 1 year. Ideally, you have to triage it with the HPV DNA.
Okay.
But this repeat cytology in 1 year is also fine. If the facilities are there, you can go for the colposcopy, but not the treatment lead. Okay.
Okay. Okay. Next slide, please.
I think in our scenario, doing colposcopy and HPV DNA is perhaps better, because to wait for a year, you don't know if this patient will come back after 1 year. And, for her also, the mental anxiety is tremendous.
Yeah, so because follow-up may be poor and we may lost this patient, and she can come with any high-grade lesion. So next slide, please. So as this is from again Foxy GCPR, as when we do the primary cytology screening, that is conventional or LBC, if we get the negative smear, then as a routine we follow up after 3 years. And if we get an ASCUS or LCell, then in ASCUS again it can be triaged with the HPV, as rightly said by Dr. Sarita. And then if it is negative, then again we have to repeat it after 1 to 3 years. And if it comes positive, then definitely she is has to put for the colposcopic examination. And when we do colposcopy plus biopsy in ASCUS positive, HPV positive, and low grade lesion, then if the lesion comes as SIN1, then again we can do the rescreen. And again after 1 or 2 years we have to see her cytology and see to that she comes for the follow-up. And if lesion is SIN2 and then we are SIN2 plus, then we have to decide about the ablasive therapy or the excisional therapy. So there are few you can say the eligibility criteria. Depending upon that, we will choose the patient whether we want to put them for ablation or the excision. So my question, next question is to Dr. Geetanjali. Will you tell us like what are these criteria and how will you decide which patient you want to put for ablation or the excisional therapy?
So for ablation therapy, it is a destructive method wherein whole of the transformation zone is destroyed either by heat treatment, that is a thermal ablation, or the cryo treatment, that is a cold treatment. So there won't be any biopsy specimen tissue for the histopathology other than the guided biopsy. So for this, the squamous columnar junction should be nicely seen on the exocervix 1, and the lesion should cover less than 75% of the exocervix, and there shouldn't be any suspicion of any glandular lesion or any invasive component. And the patient is not pregnant. There shouldn't be the relative contraindication like infections. Also to be, if there is infection, treat the infection and this thing. And type 2 and type 3 lesions, that is the lesion going inside the cervix, cannot be treated by the ablative treatment. Yeah.
Yeah. So depending upon the type of the lesion and TZ zone, we have to think like whether we'll go for excision or the ablation. Thank you. Now our next case is 36-year-old smoker. PAP examination is showing. Next slide, please. Shivani. Yeah. So again, my question to Dr. Santosh, like how will you read this slide and what will be your interpretation?
So again, here we see, to be very frank, this is not too abnormal looking, but there is some nucleomegaly. There is a binucleate cell, and then there is a very clear perinuclear halo around these cells, and they are in a group. So this is what is you generally see typically in a well-stained smear of coilocytes. This is what is described. And when you see a bunch of them together, you would definitely call it a low-grade cell on pap smear.
Yeah. Shivani, next slide, please. Yes. So my question to Dr. Sarita, madam. So what will be your management options for L-cell? And in this
So for
particular lady?
So now LCL is one thing is it's a reversible condition. So I'd like to do an HPV DNA triage and I'd like to do a colposcopy definitely. And then maybe wait for some time and see if the changes, depending of course on what you see in colposcopy,
So
either
can
wait
we
for
have
some
the
time.
yeah. Can we have the next image, Shivani? Yeah. So madam, these are the colposcopic
Yeah, so
images.
here we
Yeah.
are seeing on the anterior lip quite a sharply defined aceto-white area, and it's the transformation zone is well visualized. So in this case, maybe loop excision, removing this and excisional biopsy would maybe would be a good choice.
Yeah. So next slide. Yeah. So Dr. Santosh, after taking the biopsy, if this specimen comes to you, then what will be your interpretation for this slide?
If you look at this slide, if you look the superficial layers, they are definitely showing those coilocytes with hyperchromatic nuclei and very nice clearing around the nuclei you can see, which are typical of coilocytosis. So this is a very nice classically described SIN1 lesion.
Yes. Yes. Next slide, please, Shivani. So, Dr. Meeta, can you tell us what will be the treatment option for SIN1 for this patient?
I think Sarita has done a good job with the colposcopy and
Yes.
complete. Then either you could repeat the cytology. I mean, I presume that there has been some sort of treatment at this time because the lesion was quite large with thermal or cryotherapy. So, and definitely call her back for follow-up to make sure that the lesion is not increased. And tell her about her smoking, to stop smoking.
Yes, correct. And the healthy lifestyle and all those things we have to mention her. Next slide, please. But definitely these patients are not for hysterectomy.
No.
So this is very important even when we teach our PGs to know like SIN1 or they see any abnormal thing, they feel she should go for the hysterectomy. Yeah. So our next case is 34-year-old, married since 25 years, 4 normal deliveries, no previous cytology abnormalities. Next, please. So Dr. Santosh, again, these slides come to you. So how will you interpret this image?
So these are intermediate squamous cells and they are showing nucleomegaly. And yeah, probably I would call them as sketch or something.
Yeah, next please.
Sorry, what did you say? I missed it. What would you call it?
Yeah, this might be as sketch also. Some of them are very hyperchromatic.
Sketch.
As sketch.
As sketch.
And there is some nuclear abnormalities and you can see that the chromatic is not great. Possibility of high.
Yeah. So Dr. Gitanjali madam, this colpo, if you see for this patient, then how will you interpret this colposcopy finding? This is after application of acetic acid.
There is a nice dense aceto-white patch in the anterior lip of the cervix and with the regular margins. Vascular changes may be there, may not be there. Cannot make out clearly.
But we don't have the, unfortunately, green filter image, but we have the Lugol's.
Yeah, it really is a high-grade lesion. And
Oh.
it is an adequate colposcopy and type 1 lesion. Because squamocolumnar junction is nicely seen and the lesion is also nicely seen on the cervix.
Shivani, can I have the next image? Yeah, so
Yeah, there is no uptake of Schiller's test is positive.
positive.
So all these things favor high-grade lesion.
So we need to biopsy from this area, right?
Yeah.
And after
Multiple
taking
biopsies, multiple biopsies.
multiple biopsy. Dr.
Why not take
Santosh,
one loop biopsy?
That is possible in a OPD setup. You have to, then again, one more sitting, you have to go in for it.
Oh, don't do OPD.
Okay.
Dr. Santosh, after taking biopsy from Dr. Gitanjali, this comes to you.
Yeah. This is a very straightforward high grade lesion, at least SIN 2. So I won't call it SIN 3. You can see
Yeah,
good number of
SIN 2.
coilocytes. So generally in SIN 3, you won't generally see so many coilocytes. So this is at least a SIN 2, which translate to HSIL on cytology actually.
Yes.
In this, Aicc will help you.
Yes. So
Yes, Aicc P16 would be positive in SIN 2 because this is a high risk lesion and it's probably has integrated the DNA of the high risk HPV. So P16 would be surrogately positive, block positive in this.
yes.
So, Dr. Santosh, why you're not calling it CIN3, you said?
Because it's not showing the abnormalities on the whole thickness.
Whole thickness
It's
is
still
not involved.
2/3. I can see a lot of coilocytes still hanging around there, which is generally so it's not completely full thickness. It's SIN 2, but at the same time it is HSIL and the bracket you will call it SIN 2. It's a high grade lesion, but it's a SIN 2 high grade lesion.
Oh, okay. Thank you.
So Gitanjali madam, what options you will have for this to treat this patient? Sarita madam already partially answered it, but to
Yeah,
complete the case, yeah.
She is 34-year-old
Yeah.
and she has completed a family.
Family, yes.
So in that way, you can do an excisional treatment.
Yes.
So LEAP is the preferred treatment for this patient.
Yeah, we can remove the Santosh for the margins and everything. Yeah, correct. Can we go to the next case, please?
Right.
Next slide, Shivani. Next slide, please. Yes. So now we have this case of 45-year-old para 6 asymptomatic, no gynecological examination in the past, non-smoker, and her first pap smear at 45 year of age is showing these images. Next, please. Yeah, again to Dr. Santosh. If these images come to you, 45-year-old, first time, her pap is showing this. So
Yes, so
how
you
will
can see
you
on
label
the
this?
right side, you are seeing more or less normal cells which have got small nuclei. But on
Yeah.
the left side, you see the image where you have basal, parabasal kind of morphology of cells with very, very high NC ratio. And the nuclei look abnormal. In some of the cells, the nucleus is almost filling almost 80-90% of the cell. So
Yeah.
this is very typical characteristic of high grade cell HSIL.
Shivani, please next. Yeah, as you rightly said, it is HSIL. Then next, Dr. Samar, like what are the next slide, please. What are the management options for this patient?
Colposcopy, obviously. She needs a colposcopy, and depending on the colposcopy, you would biopsy it then or similar. Actually, it mirrors the last case, in the sense that at colposcopy, if it's a very small isolated lesion, I'll biopsy it. If it's something very large and it's looking a little ugly, I'll consider doing a leap also for that patient. So let's see. Depending on what the colposcopy shows.
Yeah, so now these are the colposcopy images. Next slide, please. Next slide. No, previous. Shivani, previous. Yes. So,
Yeah, so if you
can,
look at it, this is similar to the last case, but worse, I would say.
yes,
It's very
because
well
here we can
demarcated.
see the
Yeah,
branching the vessels and everything very
absolutely. So
clearly. Yeah.
acetocyte area plus subnormal vasculature. So
Yes.
for me, in this case, I would definitely poster for a nice leap or something like that.
Nice. Next slide,
Yeah.
please.
Vijay, I have one question for Dr. Santosh. I want to ask him how easy or how difficult is it to comment on margins with the LEAP specimen?
Deep, yeah, it's a fragmented thing. It comes in fragments. It's generally longitudinal bits of tissue. So we would submit it entirely, of course, of both cone and leaf. We would submit. We would look. It is not so difficult. The problem is, I think you use a kind of cautery
Yeah.
to cut through it. So there are cauterized issues. So when I see samples from different labs, sometimes the cautery effects are different, and that can interfere with interpretation sometimes. But otherwise, we pretty much easily can tell the margins.
In
Yeah.
fact, I would say that if I'm going to do a procedure on this patient, it would not just be a leap. I would do a little bit of a larger leap, like a shallow cone or a regular cone also. She's 45, para 6,
Completed her
so
family, yes.
yeah. So I
Perimenopausal.
would be happy to do a decent cone also for her.
She's a para 6. Does she have any element of prolapse, which is just making the lesion worse? Just asking. I mean, yes, she is the colposcopy and findings, but is there any because you wrote para 6, so I'm just asking whether
Yes. So, madam, that details were not available with us. So, and next slide, please. Yeah,
And
here
see,
clearly we can see the abnormal vasculature. Very
What's
scary. Yes. Next, please.
Next, you can see nicely.
Yeah. So after taking her leap or a biopsy, this comes to you, Dr. Santosh. So
Yeah,
what
this
you
is,
think?
you can
Like,
see that all the nuclei are looking abnormal and they are extending from the basal layer till the top. So this is a pretty much typical SYN3 lesion which you would see
yes.
in report.
So, what are the treatment options and how will you follow up, Dr. Samar?
So
What
again,
is
if I manage to do a pretty big leap or a significantly large biopsy where all the margins and everything is negative, then I can follow her up. But if it's not, then I'm more than happy. If it's a punch biopsy with a CIN3 in a 45-year-old, I'm happy to offer a hysterectomy. I mean, all controversies apart. Uh,
Yes, Samar, I would
Samar,
ardently
any
look in a
role?
leap.
because even her history, as we said, she's para 6, living 6. Never means she this is her first pap smear and which is showing this cytology. So less likely this lady will come for follow up and she will listen to us. So practically, even I agree with Dr. Samar. Mm, yeah.
Yeah, I
But
think one more thing in leap we would definitely try to look is there some micro-invasive focus for a stage 1A1.
Yes,
absolutely.
That's true.
that's true.
No,
That
I had one more question for Samar. Is there any role of doing frozen section to check margins?
No.
No, madam.
No, I think Santosh will be the first one to
No,
say
not at all. I've never seen a frozen section for a leap.
Yeah.
okay.
Cone, maybe, Santosh, cone for a good cone.
No.
Not really, no?
Cone. See, we are in any case going to examine it completely. It's fine.
Right.
Yeah, and I think now post cone or post leap, you do a top hat also as a separate biopsy you send, which is like a margin at the endocervical canal end. I think so. Top hat biopsies come separate to us.
Yeah.
So we had a fantastic panel discussion with our experts and
Just
we
one
got
question.
a
Since
yes,
we have time, Vijaya.
yes,
uh,
madam.
If we go for hysterectomy for this lady, what will be the follow-up? She will need a follow-up even after hysterectomy.
follow-up
Walt
has to
smear.
be similar. Yeah,
Walt smear.
similar to
smear.
in the conservative management of cervix only. 1 year first follow-up will be after 1 month just to see the walt healing status. Then you can do a pap smear and colposcopy after 6 months. Then HPV or cytology, whatever available at 12 months, 2 consecutive negative smears has to be there. Then as per the GCPR guideline, once in 3 years cytology or once in 5 years HPV testing can be done.
Thank
But she has to continue the screening for the next 20
Walt.
years.
20 years. That is very important. We have to make her understand it is not like that. She may feel the disease is out, so now disease free. But we have to educate her about her scene 2, scene 3, and how it can even progress to the vault. So that education is very important for such women when we operate them for the scene 3 lesions and the high grade lesions. So
just had
with
a
this
question.
fantastic panel discussion, now I request Dr. Anju Madam to tell us few take-home messages and few points for the clinical practice.
Yeah, so it's not me. I will ask every panelist to give a take-home message in screening and how to manage. How to screen is mainly two ways. Either we do primary HPV testing or we do co-testing. I personally feel when we do, it is better to do both together, HPV with the pap smear. Second is via Willy for the low resource setting and manage accordingly. How to manage screen positive HPV or pap smear, we have discussed that. Anything anybody else wants to say?
I
And
just have a question. If the last patient, sorry, I'm going back, was
Yes.
only 30 years old and had three children rather than 6, any role of trachelectomy? Just asking. CIN3?
Dr. Samar, would you like to take this question?
Yeah, I mean, there is a role, but I would say if you do a good cone biopsy and your margins are negative, you're sorted it out. I mean, I don't think trachelectomy. The question for trachelectomy is what are we trying to achieve as the endpoint?
I get that, but there is
Yeah.
a lot of debate between the gynecologist and the gynecologist. While we would probably say, let's just do a hysterectomy, and
Yeah.
a lot of gyne-oncologists push them towards a trachelectomy. Sarita, what are your views? I've actually got a patient, and there's a struggle trying to convince more. What are your views, Sarita? 35-year-old, two or three children, whatever, SIN3.
Hysterectomy. I really have very little experience with trachelectomy, but so I
I
can't
mean, at the end
say.
of it, if the trachelectomy also doesn't work, you're going to land up with a hysterectomy. I just wanted your views because
No, I think when it comes to, if I might just add, if it comes to something like a pre-invasive disease like CIN3, right? I don't see a role of trachelectomy at all in that, because you do a big, nice, thick cone biopsy. If you still have disease beyond it, then any which ways one should go for hysterectomy. The role is more so for stage 1A ones, for fertility preservation, small
yeah,
disease.
I get
That
that.
is
No,
yeah.
I'm specifically asking for SIN3
Okay.
because that's CIN. I mean, the rest of it is agreed.
I know.
Thank
It's a
you.
very technically demanding
So
procedure.
Summer, let me add another spice to this.
Yeah.
You do a cone or you do a leap, and I say that the tumor, the SIN3 in situ is involving the endocervical margin or something. If I can identify the endocervical properly. So what would you do in such a case? Would you advise a patient hysterectomy in such a case, or?
No, if it's for fertility preservation, somebody young, then I would go for a much larger cone again, like a recone, a recone biopsy or something like that, and try and get that entire thing in. Trachelectomy, one of the reasons why we are reluctant is because our experience with doing trachelectomy is also very limited. I have till date, I have not seen a single trachelectomy. Let me be honest on record.
I've never seen a specimen of trachelectomy, at
Exactly.
least in
So
TMH.
I'm sure there are people who are doing it, but
They are. The gyne-oncologists are. And I'm just surprised that somebody who's finished her childbearing with SIN3, it was a specific SIN3, nothing more. So anyway, thank you for your comments.
Thank you everyone. One last question, Dr. Santosh. How easy it is to see LVSI on a cone specimen? Many times.
LVSI without an invasive cancer would be very, very unusual, Dr. Anju.
Right.
So I would probably find a invasive tumor and then an LVSI. I don't know the last time I've reported just an LVSI, plain LVSI in a SIN3 specimen. You would have an invasive cancer. And that's what we ardently look at. We take deeper sections of the cell so that we look and clearly find that there is no microinvasive T1A1 cancer.
Right. Thank you. Thank you, everyone.
Thank you.
Thank you so
Ma'am,
much.
if I may just ask two basic questions to all our panelists.
Yes.
One is, I had a patient once who came in my OPD who had a normal pap smear and her high risk HPV was positive. And her gynecologist had put her on vaginal probiotics, saying that that is going to help your vaginal immunity and help kick the HPV out. So, one, I want to know what is your view on that. The second thing is when you get when you do patient pap smear for your patients as a routine screening protocol, and you see a pap smear that shows moderate inflammation or severe inflammation, but without any NILM, do you give any empiric treatment or you just follow up? If you do give empiric treatment, what do you do? Any
So,
of our
Latika,
panelists?
I can help you. I can answer maybe the
Second one.
first question. I think what can you tell me again? What was your first question?
Probiotics.
So this patient came in who had a
the
high risk
probiotic.
HPV
Okay,
positive, and the
Ah.
gynecologist told her that vaginal probiotics will help you flush the HPV out faster by building
No,
immunity.
no. So see, I don't think that there's any evidence or any a guideline to substantiate this. We definitely give overall immunity improving, and maybe if there is concomitant vaginal infections, there may be a role of probiotics for those infections, but per se, there's no evidence for that to give for probiotics.
Madam, you are on mute.
Mute.
I'm not saying anything more.
Oh.
So the bottom line is the probiotics are not going to help the HPV go away. General
If she has a history of recurrent infections, treating the infection and giving the probiotic in a HPV positive patient might help.
Maybe your second question, where she has repeated infections, you treat her with antibiotics and then give her a course of probiotics and make sure she.
And also, even if the pap smear is inflammatory, you should do a colposcopy. The pap smear is not always, it is not a sensitive test. So you can do a colposcopy. If there are lesion, take a biopsy. Otherwise, in a symptomatic patient, you can treat the T-zone with a ablative treatment so that recurrent infection to a certain extent will be minimized.
So even with mild inflammation, madam, you would recommend doing a colposcopy if high risk HPV is positive, or only for moderate and severe inflammation?
See, but if she is symptomatic and unhealthy, large erosion is there, it is better to do a colposcopy. And because she, in that way.
All right. Thank you.
So,
Thank you so
Latika, in
much.
your patient, only PAP was
Because
done. HPV was done in the second question.
Yeah, an HPV and PAP smear was done. So
And
PAP was NILM and moderate inflammation, and the HPV was positive
What
for
did you
HPV
see at the
16.
cervix? That's also
16 was
important, no?
positive.
Normal looking cervix.
So we should do
cervix, you have to follow up.
Follow up.
Just follow up. Okay, ma'am.
Right.
Thank you so much.
so much. I need to leave. Thank you so much.
Thank you very much, Dr.
Thank you
Latika.
very much.
Congratulations on a very informative webinar.
Thank you
Thank
so
you so
much.
much.
for
Thank you
Everyone
so
has
much,
given very
everyone.
practical and logical tips.
Thank you.
Thank you,
Dr.
Anju. Thank you,
Latika.
Purnima. Thank you.
Thank you so
Bye-bye.
much,
Good night.
Thank you.
the entire
Thank you.
AMW and AICC RCOG team for such a fantastic webinar. And a special thanks to our chief guest, Dr. Mandakini Megh Madam and Dr. Saraya Madam, whose vast experience, helped us, really motivated us to understand and say, why not us? And I think the discussion today has given us a lot of small tips to help our patients better. So thank you so much for this initiative. And Dr. Anju Hazari, Madam, thank you so much for having all of us. I think the panel was amazing and a lot of take-home messages for all of us. Thank you so much for your valuable time.
Thank you. Thank you all the panelists for staying back. So
you
we
so
have
much.
finished well in time. Thank you.
Thank you.
Thank you. Have a good night.
Thank you. Thank you. Thank you very much.
Thank you, everyone from Corona Remedies team. Thank you.
Thank you. Thank you, Corona Remedies. Shivani, thank you very much.